welcome and thank you for joining us to the first PCNA webinar of 2026. So my name is Sarah and I am part of the PCNA Steering Committee. So before we start, I'd like to acknowledge the traditional owners of the lands throughout Australia and recognise their continuing connection to the land, waters and culture. And I pay my respects to the elders past and present. I'm currently in Darwin on the lands of the Larrakia people. So PCNA are running these sessions and they are designed for palliative care nurses, but this particular webinar, after having the registration, has actually been joined by more than just palliative care nurses. This is a webinar for palliative care in general, I would say. And we want to be leaders in palliative care education and conversation. So this is where we are, and this is how we've been brought to have Kaz with us today, Caroline. So today's session will be presented by Caroline Phelan, and she will cover what is new in palliative care analgesia and new approaches to palliative care, pain management. Look, this really is clearly a topic that's captured attention and interest. And I think that's because we always, as healthcare workers, want to grow and to be doing the best things for our patients. So welcome, Kaz or Carolyn. I'm going to say Kaz. I'm going to say Kaz. But before we get going and officially started, there's a little bit of housekeeping I want to go through. So throughout this webinar, we would love you to use the chat function. So clearly many of you are doing that now, which I'm really appreciative of. And I hope as you are, you're looking there and going, oh my gosh, we're all across Australia and here together, which is very exciting. If you have questions for Kaz, what we will do is she will speak. She's got a ripper of a presentation, and then we will use a combination of what you are asking in the chat and also the questions that you gave to us before the webinar. Now, just keeping in mind that it is quite a big audience today, so we may not get to all of your questions, but if there are burning questions, we can certainly ask Kaz to consider answering them at another point or a second webinar. We are going to use closed captions today, and they've been enabled. So if that's what you need to use, you can turn that on yourself. So that's kind of handy if you're in a loud workplace or not everyone's as interested in analgesia as you. These sessions are being recorded and you will be able to watch it on YouTube after this. So that's kind of cool. And I would encourage you to share it because that is what we want. We want these types of conversations to be spread far and wide. And we also appreciate your feedback, and there will be a survey sent out immediately after the webinar. So we are delighted. You can see her. I imagine you can see her quite well. But Kaz, do you want to wave for us? There's Kaz. So I'd like to welcome Caroline Phelan, and she is a senior lecturer at Flinders University in palliative and end-of-life care. She's a nurse, and her clinical background is pain. So, of course, she was the perfect person to present to you today. So, without further ado, welcome, Kaz.
Thank you very much. Yes. Thank you. To be able to see that what's new in pain management in palliative care. So I've got a couple of slides today. Thank you to everybody who sent in a question. There were a lot of questions, quite diverse questions, and obviously we don't have time to go into all of the questions today. I'm going to try and cover as much as I can, but what we might do is think about circulating some responses via blogs. And so and perhaps do another webinar maybe later in the year when I've had an opportunity to have a Bex and a good lie down. So I'm just going to start with a few areas. So I'm just going to cover some of the new things or some of the things that perhaps you haven't thought about using in pain management in palliative and end-of-life care. And we're going to be talking a little bit about patient-controlled analgesia and a new anxiolytic that's floating around, and a couple of things like intranasal delivery as well. So I think the first thing to say about pain management is good pain management starts with thinking. And it starts in the place where you need to be thinking about what sort of pain am I looking at? Neuropathic, nociceptive? Is this acute? Is it episodic? Is it breakthrough? What am I looking at? What have I given that's worked? So what's already working? Did the last dose I gave work? Did strategies I've got in place help? What's happened last time? Were there side effects? Did nothing happen at all? And what am I planning on? What's my goal now? Is somebody trying to get some sleep? Are they trying to just aim for some comfort? So this is really helpful to start thinking about. When we assess pain, there are a couple of different tools, and we're all very familiar with the verbal numeric rating scale, and the faces scale, and the big round happy faces, and then the alien type Wonka faces as well. What's really interesting is as we age, as the human brain ages, our ability to understand horizontal scales shifts to vertical. So we are much better able to understand a vertical scale like a thermometer than we are a horizontal scale like a sliding scale. So a team in Iowa, Keela Hurd's team, came up with the pain thermometer, and I know that it's been adapted for other symptoms like distress and anxiety and things like that. A thermometer is a really great tool, and I've worked in plenty of facilities where we've laminated a couple of these and walked around and said, where's your pain? The team at Iowa put some language there. They put some numbers there to help our medical colleagues because they feel much better if we talk to them in numbers, don't they? And it's particularly recommended for older people, but you can use it for people who are non-English speaking because the thermometer is a universal experience. You can use it for people who are cognitively impaired as well. People who are confused understand a thermometer. So I think the thermometer is a really useful tool, and I'd encourage you all to pop out and get yourself one. Understanding pain can be really difficult, and I think it's really important that we recognise that we often observe pain in others, and we often ask them about their pain and then wait for a response. And one of the interesting things that's been developed by a group in Utah is the clinically aligned pain assessment tool. And these are a series of questions to ask your patients to develop a pain plan. So we don't ask people if they have pain, you ask if they're comfortable. If you're uncomfortable, is it tolerable or is it intolerable? Are you comfortably managing? Do you have negligible pain? So we're talking to people about not just do you have pain, are you comfortable? Is your pain getting better or worse? Are you feeling like you've got adequate pain control? Is there something that you would like to reduce or change about your pain management plan, about your medication? Can you do all the things you need to do, or is the pain stopping you from doing that? So we're asking about function, which is incredibly important because we know that particularly older people are less likely to respond to higher intensity pain and more likely to complain or respond or tell you they have pain if it is interfering with their function. So that's a really important thing. Can you do most things, or is pain getting in the way? Is pain stopping you from doing things? How are you sleeping is a great question. Because if people are awake with pain in the night, you know you're not hitting the mark. So these are the questions that we encourage people from a pain service point of view to ask their patients in a conversation. What you're then doing is you're actually having a conversation with somebody and you're empowering them to take control of the pain and their comfort as well. So that's a really great tool. It's been validated in some surgical units and medical units, and there is a trial going on in the US, I think, in palliative care as well. So let's get on to patient control. I think one of the big things that's starting to happen here in Australia in adult palliative care is this conversation around patient-controlled analgesia. So we've had patient-controlled analgesia in Australia since 1981 in the acute setting, so we're very good at it. We've been practicing for a while. And you can do PCA via IV, subcutaneous, epidural, intranasal, even regional nerve blocks. You can do patient-controlled analgesia. And they also have oral patient-controlled analgesia devices as well, which are these really cool little things that have a code and anyway, that's quite complicated. There are significant advantages to patient-controlled analgesia, and what we know since 1981, we've been able to prove patient-controlled analgesia reduces total opioid use. When a person has the button themselves and they're pressing it for themselves, they use less opioid. It saves time, set up time for the nurses staff. You don't have to go and get a PRN. It's at the bedside. Patients press it themselves, and it improves overall satisfaction of patients, family, and staff as well. And I think we all want to be happier. For palliative care, the same advantages that occur in the acute setting happen in a palliative care, end-of-life care setting. But other things that you may not think about with patient-controlled analgesia or not have thought about with patient-controlled analgesia, it is incredibly useful to find a 24-hour dose. If you have somebody who's coming into a hospital and their pain is out of control, patient-controlled analgesia can really help you understand what it is that they actually need to manage their pain. There may also be some advantages for its use in dyspnea. We've had some case studies where patients on very low dose PRN morphine for symptom management of their breathlessness were given a PCA and found it significantly improved their symptoms. And I think that was all about control. They didn't have to wait for the morphine. They could just press the button and it was right there. Subcutaneous opioids are very safe, well proven. And one of the great things about patient-controlled analgesia is you can transition to a nurse-controlled or what they now call authorised agent control. So if you're dealing with pediatrics, for example, you can train mum and dad to press the button appropriately. You can train carers to do that as well. The difference transitioning from self-administration to authorised agent or nurse administration is you often extend the lockout. One of the great safety features of patient-controlled analgesia is the fact that when somebody's had too much opioid, they fall asleep and they stop pressing the button, which makes it nice and safe. When you're pressing the button on behalf of somebody, you just need to extend that lockout. So you're providing that level of safety and security around that. A barrier to patient-controlled analgesia for many years in palliative care has been the fact that the pumps were large and needed to be plugged in constantly. That is no longer the case. And I've just got a picture there of one of the ICU medical pumps, the CAD Solus, and you can see there, that's not a giant's hand, by the way, that's a little lady's hand. They're quite small and neat, and they come with little bags that you can sling over your shoulder. I don't think anybody's rushing out to buy the handbag, but they're certainly very ambulatory now, which is a change over the last couple of years. There's been some research in palliative care and more is coming. There are a couple of units around Australia, for example, who are doing research in this space. Flinders Medical Centre is one, the Gold Coast Hospital's another. In a recent summary of evidence, these guys found that PCA was safe and effective at managing cancer pain in a palliative care setting. PCA demonstrated rapid pain relief, so really useful when you have to get somebody out of pain quickly, improved symptom control, and enhanced patient autonomy, which is essentially how and why it's so good. Adverse effects were consistent with opioid use, not with using the PCA. So they're a very safe mode of delivery for patients. Another way that you can deliver patient-controlled analgesia is intranasally. And the intranasal route is a really handy route. We use it a lot in emergency departments and for procedural pain around various places. It's fast, simple. You don't need access because most people have noses. It's also a great mechanism because what happens is the transport molecules in the nose essentially take the drug to the bloodstream really quickly. So it's quite effective. Common medications that we use intranasally: fentanyl, sufentanil, ketamine are really good for procedural pain. Dexmedetomidine, just because I love saying it. And midazolam. Now, just a quick note, midazolam does sting quite a lot. So in my experience, midazolam causes people to tear up, which produces a lot of fluid in the nasal cavity. So you probably only have one or two goes at it. You can also give other medications, ketorolac, naloxone, obviously, and opioid rescue kits that are in the community will have naloxone, dexamethasone as well you can give. So there's quite a few medications that you can give intranasally. What you may not be aware of is you can get these really neat little devices from a company called Go Medical that are patient-controlled analgesia devices. So you fill the chamber, screw the cap on, the patient can then administer a dose, and then it has a lockout because the inner chamber takes 4 to 5 minutes to fill. So they have to wait for the inner chamber to fill. And it's really useful when you have somebody, for example, if you're doing a wound dressing and you need to have somebody self-administering a bit of fentanyl perhaps, or some ketamine during the dressing, or some dexmedetomidine, then they can do that, and you know they can only have a dose every so minutes. They have different lockout bottles that you can purchase as well. Super neat, super easy. The other way to deliver intranasal is with a cone diffuser, which you put on the end of a syringe. And your emergency department in your local hospital will have plenty of those because they're very commonly used. But the Go Medical devices are really neat and handy. Dexmedetomidine, everybody knew I was going to go there. I do. It's a newer generation alpha-2 agonist related to clonidine. Think clonidine effects, but faster onset, and the patients are very much less drowsy. Dexmedetomidine, like clonidine, has some analgesic qualities, although it does cross the dorsal horn, so we think it's got slightly more analgesic qualities than clonidine. Great for procedural pain, used as an infusion in ICU for sedation and in pediatric anesthesia very commonly, as well as intranasally for those. In palliative care, a little bit of research being done. I know there's a team doing some great work at Wollongong Palliative Care. Really some great benefit in delirium. Seems to be much more effective than benzos or antipsychotics, especially for the hyperactive delirium. It seems to be showing great effect. Has had some RCTs, randomized controlled trials in pain management, hasn't shown a great difference in pain scores, but has reduced opioid need. So that's what we see in clonidine as well. We use clonidine in pain management a lot when we're doing really complex opioid rotations for the same reason. It's an opioid sparing option. One of the things that I think I really like about dexmedetomidine is the fact that the sedation that comes with it is really light. So the patients are comfortable, they're rousable, and it allows comfort without deep sedation, which is really nice. So you get that, the reports from palliative care are that people can interact with their families for longer, which is lovely. And there's some really good evidence that it's opioid sparing as well. So if you had somebody on very high doses of opioid, then a background dexmedetomidine infusion would reduce that opioid, perhaps give you an opportunity to do a rotation. So I just wanted to also mention a couple of gases because coming from pain management, we do use a lot of different types of medications. We use a lot of different things, and a lot of you will have been familiar with Entonox. So that is the premixed nitrous with oxygen that comes in its single cylinder. What you may not be aware of is the company has made smaller, lighter Entonox cylinders. So they're much easier to move around. And they also have a new demand valve system, which means that you can turn it on, hand it to the patient, and when they breathe in, the Entonox comes through. Many of you will have seen in various television shows and hanging around ambulance bays, because I know that's what a lot of you would be absolutely doing on a Saturday afternoon, is the green whistle or the methoxyflurane Penthrox. Now, it has become a little bit popular in some procedural pain management settings, and I just have a word. Methoxyflurane is a dissociative anesthetic gas, and it is an active agent when you breathe it in, and it's also active when you breathe it out. So unlike Entonox, which is active when you breathe it in, but inactive when you breathe it out, methoxyflurane provides or presents itself with some occupational health and safety issues. Because if you're standing next to the patient, you're getting exposed. And repeated prolonged exposure to methoxyflurane will probably give you renal cancer, which is a bad outcome, really, for you at work. But the company has developed a carbon filter that sits, that's a little black thing on top of the green whistle there. And the idea is the patient breathes out through the whistle and the carbon filter captures the active gas. I think Entonox is a great solution, particularly if you're having to do dressings, if you're needing to put in lines, that sort of thing. It's quick, simple, starts working the minute somebody starts breathing it in, stops working when they stop breathing it, which is quite handy. So I'm going to talk a little bit about opioids. I'm just conscious of the time, so I'm going to try and be entertaining and quick.
You're good for time, Cass.
Okay.
We're in. Yeah.
All right. Obviously there are a lot of opioids on the market. It's really useful to think about opioids and their primary receptor. The three main opioid receptors, mu, kappa, and delta, all have slightly different jobs in our body, if you like. And so whilst mu is the primary analgesic receptor, sedation and other things come in play when we talk about kappa and delta. There is some science that some of those opioids that work primarily on the delta receptors will do better in types of neuropathic pain. But it is worth thinking about sort of what am I administering to my patient. The most common opioids used, actually the most common analgesic used in Australia at the moment is tapentadol, which is absolutely everywhere. and is an atypical centrally acting analgesic. That's what we called it. So it is a medication that many of you will be familiar with, tramadol, and tapentadol has sort of been touted as the next generation. It's worth noting that tapentadol has a higher affinity to mu receptors than tramadol. So you're giving a stronger opioid than tramadol, just so you know. Atypical centrally acting analgesics can be a little tricky if you have somebody on a large number of other medications. So it isn't as popular in palliative and end-of-life care, but is incredibly popular in surgical units, which is why it's the most commonly used opioid in Australia. Morphine, I think, still stands as the number one gun in the armoury. It is in competition with oxycodone, which has also been very popular. One of the things that often we have a problem with morphine are the preparations that are available. You know, MS Contin has a really good bioavailability for a BD dose. OxyContin also has a great bioavailability. So you can give OxyContin BD and you know that patients are going to get their medication pretty much across the 12 hours. Kapanol is a little bit shaky on the bioavailability, and sometimes you have to give that TDS to get a reasonable spread across the day for a slow release opioid. Hydromorphone came onto the market with gusto a couple of years ago, and its daily slow release preparation is really popular. Hydromorphone's great in that it's got good bioavailability, so it's well tolerated by most people. The Junista dose, or the long-acting dose, lasts most of the day, and it is safer to use in renal failure, and so it gives you a really good option for people in renal failure, other than as opposed to morphine, which you can't use. Fentanyl, again, super popular, transdermal, really very renally safe. There are really good, robust studies that show that prolonged exposure to fentanyl does cause increased tolerance. So you will get tolerance to fentanyl more quickly than you will to other opioids. There are a couple of things to be said about that research. You always need to make sure that people are absorbing their fentanyl through their skin adequately. And you do need some fat on your bones, and you do need circulation. So it can be problematic. We also know there's a subset of the population that doesn't metabolize fentanyl particularly well. So if you find that your patient isn't responding, or you're needing to go up on the patch more quickly than you expected, you probably do need to shift opioids. Methadone is, just with fentanyl, great for intranasal, so rapid onset, really good offset, and is well tolerated subcutaneously as well. Methadone is a great medication, and all the people who work in pain management give methadone a little hug and make it feel a little bit better because it gets such a bad reputation. But the reason why we use it in addiction medicine is the same reason why pain management like it so much. You get this long therapeutic window where you've got this stable, once you get into a stable dose, it's got this beautiful long half-life. That does make opioid conversion with methadone difficult, because of the half-life, and because conversion from methadone changes with the dose of methadone. So it isn't as static as the other opioids. So I always say, if you're trying to do anything with methadone, get yourself a friend on the phone with a pain medicine specialty, our palliative medicine specialty with conversation around methadone. Methadone, people who come in are at end of life who are on methadone for addiction medicine can actually benefit from splitting their daily dose into BD. One of the first things I often recommend is if you have somebody who is a former IV drug user and is on a stable dose of methadone, they won't want to go up on their methadone. They really work hard to keep their methadone at a stable, as low a dose as they possibly can. But if you take that dose and split it into two, you get improved analgesic quality without having to increase the dose. And you can also then give them other medications as well to help manage their pain. Buprenorphine is quite popular for a number of areas, particularly older people. You get the patch. Sublingual buprenorphine is great. It's fast acting. It's useful for acute pain. It can be used in a pain crisis because it's absorbed really quickly under the tongue. And it is a real option for people. So something to be mindful of is I haven't seen a lot of sublingual buprenorphine used around palliative care, and it is a really good option. When we're doing opioids and when we're thinking about opioids, we talk about conversion, and this is a little tool that I used to use all the time. Just gives you a quick and easy way to do your dose calculations. And just so everybody knows, my slides will be available to you afterwards, and I'll provide a reference list as well. So no need, Michelle, you can stop taking, I can see you taking photos there. We don't use a lot of codeine anymore. Famously, codeine is known as a great anti-diarrheal with some analgesic qualities. So we don't like codeine very much anymore. But what you can do, for example, with this, if you take the fentanyl patch micrograms per hour and you times by 3.6, that gives you your morphine daily dose straight up. Nice and easy. Now, I was talking to Claudia Verdon earlier, and she did point out to me that everyone has their own opioid conversion. You know, this is what I like and this is what I don't like. So I will happily give you these calculations with the caveat that your team might go, she's crazy. She's got no idea what she's talking about. That's not what that equals. This equals this. But anyway, it's just some nice, simple math for you on a busy day. But I would very much caution methadone conversion is complicated. And so I don't give those calculations out. But I could probably be plied with cocktails. Anybody wants to send me large cocktails, I could probably provide it for you later. So I just wanted to take a little moment and spend some time on some non-medication options. And VR is something that's really becoming the cool kid on the block, although I still think dexmedetomidine is slightly cooler. So there's some good evidence for short-term pain relief for VR. And this is in a number of different studies. They've done a reasonable amount of research around using VR for things like catheter insertion on kids receiving chemo and things like that. So repeated needle stick, pain, using the VR to distract kids and young adolescents. It's been pretty good. There's also some good evidence around psychological comfort. So it's much more feasible now than it was 10 years ago, and becoming more and more feasible and very acceptable. It remains an adjunct therapy, so I would never just use VR for pain management. And it is best suited in the presence of psychological distress. And I would say, in my experience, and I've been in 2 VR studies as a pain CNC, anticipatory distress around pain, it works really, really well. If you can sit a young child on a roller coaster and then do their needle stick, they don't notice the needle at all. And it can be useful in situations where you might have a lot of side effects from the opioids as well. But the technology is getting better and it's coming along quite nicely. So what I thought I'd do is just finish up before we get to sort of questions and then open the floor to everybody with your questions, is just sort of give some little tips and tippies that I've learned through the years, even though I'm incredibly young. I started nursing when I was a child. It's much easier to get out of pain, to stay out of pain than get out of pain. So it's really important that we let our patients know that if we can keep them out of pain, that's a better option for them. Paracetamol is an interesting drug. I'd just like to say that the current Secretary of Health in the United States is not speaking from a scientific basis at all. We might call him in the pain management community a complete numpty. But what is really interesting about paracetamol is it's everywhere. Everybody uses it, but a lot of people don't realize that they have paracetamol actually has a short half-life. So if you have somebody who feels a bit nauseated when they take 2 tablets every 6 hours, or they're not getting a lot of relief, if you give 1 tablet every 3 hours, you actually get a better therapeutic coverage from the paracetamol. The other thing that we don't talk about a lot is loading doses with paracetamol. And in fact, we probably should use loading doses for paracetamol to be quite effective. But paracetamol kind of doesn't get used very much because people perceive it as a weak analgesic and not really doing much. And I guess in the grand scheme of things, you need to make a decision about how useful it is to add. There are opioid-sparing qualities to it. But I find, particularly with older patients, 1 paracetamol every 3 hours is a little neat trick. One of the great things around opioids is it's not about size, it's about your physiology and your age. So age is a greater indicator of what dose you need than weight. And that's really important when we, think about titrating to effect. So with older people, you always start low and go slow is the story there. It's really helpful to think about which opioid you're using and what pain you're treating. And I also like to just remind people that morphine can be dysphoric. So if you see a change in mood, there are many, many reasons why there would be a change in mood. And I'm not saying that it's only the morphine, but you might consider changing the morphine to another opioid. Particularly higher dose morphine can be incredibly unsettling to a personality. Alternative absorption is a really nice thing to think about. So tramadol comes in a liquid form in drops, and that's actually absorbed sublingually. If you need something sublingually, tramadol drops is useful. Temgesic is also really useful. I know there's a new ketamine lozenge coming out on the market as well, which can be good, or the intranasal option as well. Low-dose amitriptyline is really commonly used in neuropathic pain. And neuropathic pain is a really difficult pain to treat. There's all sorts of different approaches. The International Association for the Study of Pain have just revised their guidelines. They haven't really changed them very much, but they have just put out new evidence guidelines. But one of the things about amitriptyline is it is incredibly cost effective, much more so than pregabalin, which I think is sometimes quite expensive. But what it can do is restore the circadian rhythm. So when people take a low dose, and I'm talking about 10 milligrams at night, what we notice in the pain clinics is that people's circadian rhythm starts to return. And so they're getting better sleep. Now, I would have to say that in itself will improve your pain. If you can rest, if you can sleep. The other thing about amitriptyline is the numbers needed to treat versus the numbers needed to harm is quite favorable. So where you have something like pregabalin or gabapentin for your antineuropathic pain that have, a very high number needed to treat, but very low number needed to harm. The opposite would be so for amitriptyline. You do have to be very careful with older people and amitriptyline and the sequelae of consequences of mixed drugs. Nortriptyline is an option as well, but I think it's always worth thinking about that circadian rhythm benefit of that. The other thing is pain occurs in the brain, and it's really important that we treat the brain in pain. Active distraction is always superior to passive distraction. A Where's Wally book does wonders in any, even at the nurse's station, let's be honest. But you will get a much better engagement. You will get much better pain control if you've got somebody who's engaged with the thing that they're doing rather than watching TV in the background. So conversations, having people come and visit, guided imagery. VR is another example of that. But very simply, we used to all carry around these little find cards and I would hand them to people and say, can you find the black dog in that picture? And people would just go for it. And that will reduce your pain as well without having to do much at all. So I've taken you on a whirlwind tour of some of the cool stuff that's happening in pain management. I'm going to stop sharing my screen. My slides will be available and the references as well. And so I'm now going to open the floor to questions.
All right. Well, so thanks so much, Kaz. I imagine you were not following the chat, but the chat was full of questions and also everyone going, oh, that's very interesting. So everyone's very engaged.
Good.
We've got a few questions in the chat, and I just encourage everyone, if there's something that you're thinking, pop it in the chat and I will try and get to it. While you're thinking, Kaz, I wanted to put out there. So potentially we have 122 nurses here with us who perhaps might be prescribers, but might be non-prescribers. And they've just heard about all these amazing different types of analgesia that is available, but they may not be using. So my question is, what are your tips for getting this across the line? Because it's obviously a team thing. So what are your go-to tips for getting our medical colleagues perhaps to consider something new like what we've just discussed today?
Oh, that's a fun question. Thanks, Sarah. I often think that getting people, particularly medical professionals, to think that it's their idea is a positive thing.
Okay.
So I start with journal clubs and other sorts of things. I would also use the mechanisms around medical students, advanced trainees, PGY2s, depending on what system you've got in your facility, in your area. They all need to do projects. So they all need to do something. And you can say, I went to this webinar, or here's a paper on patient-controlled analgesia, or here's a paper on this. Maybe we should do something about that. I think we collect enough data sometimes to be able to say where we're not doing a great job. But I think sometimes we really struggle on and now what do we do? I think use the mechanisms available to you, the other departments. So obviously pain services, anesthetic departments, there's always somebody who wants to talk endlessly like I do about dexmedetomidine or something else. I find what I did recently was I emailed an author of a paper and said, would you present at our journal club? And so they did that. They presented their research about dexmedetomidine to a group of physicians, and it was great because everybody's talking, and it was, this is fantastic. So that's a really good way of engaging. The other thing is reach out to the different companies who will always be happy to come along and chat to you about their devices and the modalities and things like that. So it's about gaining that conversation and using those mechanisms that you have already in those meetings.
Oh, I love that. That's clever, right? You just got to think about how it happens for them, right? How did change start? And actually, it's
Yep.
about the conversations and being part of the
Yes.
conversations.
Yeah.
So now, Kaz, there's a few questions in the chat. I'm going to read one. This is about intrathecals. It
Oh,
says,
yeah.
are there any recent studies about the outcomes of intrathecal analgesia and palliative care? And then there's a little bit further to go. This is from Carly. Also, I'm in South Australia and would like to know if other states are using it. We run an infusion via a port and a CAD pump. However, they're no longer making the intrathecal port kits. If people doing this in other states, or could we use an external catheter? Could you answer that, Cass?
So intrathecal opioids, so intrathecal analgesics were very, very popular for a long time in chronic pain as well as palliative pain. They are now not very popular in chronic pain. So you will start to see some of the services available to managing intrathecal, so the insertion of ports and things like that, not being as available in various places. Ultimately, intrathecal opioids are simply another way to administer opioids. So you are just giving opioid in a different way to the patient. I think infusions have their place, and I think there are plenty of instances where intrathecal has been shown to be as good as other routes of administration. I'm a big fan of patient-controlled analgesia, and I think we can do much more in that space. But I think, when you're talking about the doses that some of these people get to, I think we can get into some shaky areas. So intrathecal is still out. I haven't had a look at the latest evidence, but I can certainly go and have a look and see what's out there. But as I said, it is becoming less popular in chronic pain, and therefore there'll be less research available.
All right, thank you, Kaz. There's a question in the chat about medicinal analgesia. Have you ever seen, the question is from Michelle, have you ever seen medicinal cannabis used in pain management?
Yeah, so medicinal cannabis is interesting. So cannabis is an interesting drug because it has so many different active elements. So what we know in analgesia world is that the fundamental problem is to get an analgesic response, you almost always get a hallucinating response. What we know about medicinal cannabis is it's an excellent anxiolytic, and there is space for anxiolysis in pain management, and I think it's really important. So often the pain medicine specialists are talking about medicinal cannabis as a good anxiolytic, as opposed to a profoundly good analgesic. We're still waiting for them to grow the variation of the plant that produces the analgesic quality without the hallucination. So they haven't quite got there yet. They're working on it. They're working on it heavily. They're growing all sorts of things, but they haven't quite got there yet. So it's you will meet plenty of people who say it's fundamentally changed their pain. Fantastic. Absolutely fantastic. And what if it works for them, that's really great. It's probably more because of the anxiolytic qualities, which are incredibly important, than analgesic qualities at this stage.
Thanks very much, Kaz. Another question in there, and this is a good one, and you may, although I was going to say you may not know the answer, but actually you probably do.
I don't know, probably.
This is from Tash. Are there any intranasal medications that are on the PBS? Wouldn't that be cool? It's okay if you don't know the answer to that. We can find out later for you, Tash.
I'd have to find, I mean, is it fentanyl on the PBS?
It depends on what formulation.
I see what you mean. For community.
Yeah. So as in, I think that question is about can we get it for people in the community, or is it mostly a hospital thing? Intranasal medications.
That would be a local variation. That would be around your local rules around administration and what people are happy to use. Those Go medical devices are quite safe though, but you are putting, fentanyl out in the community. So it's how your local group would manage that.
Okay, cool. Actually, and there was another question in the chat about loading doses of paracetamol. We've got probably time. What's your go-to for your loading doses? Because I love that idea, but that's not something I've seen very often.
Yeah, so there's some good research in acute pain that we load at 2 grams. And then
right. So you just give an oral 2 grams. Righto. And then do you accommodate for the 4 gram, like you don't give them the rest of the four, you give that you've already given them the half of their dose?
You need to be very careful about your renal and liver function.
Yeah.
She certainly, that's an acute pain. I would caution loading dose without a policy for nurses.
Yeah.
I worked in hospitals that have policies, so we were all fine, but yeah.
Yeah. Okay. But the idea even putting it out there is great to put it into the sphere. So thanks.
Absolutely. Yeah.
So I've covered most of the questions in the chat there. And I just wanted to say thank you very much, Kaz, for this incredibly informative start to the year for us all. I just want to put a little plug for before you go, before everyone else goes, that the next webinar in 2 weeks on the 18th of February is about tricky to manage urinary pain. So urological pain, right? That's kind of the next bunch of symptoms that we just aren't so good at managing. So we've got a bunch of experts that are going to come and speak to us about that. Just a little bit like this great webinar with Kaz, we've got a bunch of people who know what they're talking about and are going to share their knowledge. For everyone to know that there's a palliative, if you're not aware, there's a Palliative Care Nurses Australia conference in June. And we would love you all to be there. And I'm pretty sure wonderful characters like Kaz are going to be there.
They got me on a morning workshop because
there we go. So if you liked this, you can get a bigger taste at the conference. And I think we may end up doing a part 2 of this webinar, because I imagine there's more that you could teach us, Kaz.
I'll go through the chat and try and get some stuff. And yeah, I recognise that I wasn't able to cover everything that people had sort of put up beforehand. So
yeah. Well, I think you did an exceptional job, and I still can't say the word Dexmedetomidine.
Everybody think of it as a very spell.
Look, and I think the thing that stood out to me was that things like patient-controlled analgesia reduce opioid use and staff and patient satisfaction. Wow. Right? That's what we're all about. So thank you, Kaz, for a incredible webinar. And have a lovely afternoon, everyone.
Thank you. Thanks, everyone. Thanks for coming.